Hi, I'm Andy Wible, and welcome to Timely Topics. We're going to be talking about Mercy Health Partners consolidation and expansion. And with us today is Dr. Remington Sprague. Thanks for being with us.
Good to be here, Andy.
And you're the Chief Medical Officer and Vice President at Mercy Health Partners.
That's right.
And let's get right to it. What is happening with this consolidation? I'm sure some have heard about it, but what exactly is going to be happening?
Been a fair amount of press around it. Well, you know, when Mercy merged with Hackley in 2008, one of the initiatives was ultimately to get to a single location, single what we call campus. It was part of the due diligence that we did with Hackley was to look at both hospitals, which, you know, frankly, both of us were struggling financially. We're looking into the future at challenges with reimbursement and things like that, and decided to come together to try to save significant money and still provide a broad range of services to Muskegon. So part of the due diligence was actually laid out a model for moving all services to a single location. The Mercy campus was chosen for a variety of reasons. It's easy access. The system provides a lot of specialty services, so people travel from along the lakeshore to get to us. And the location by US 31 is more convenient. The campus there is larger. It's not landlocked the way Hackley's is, so it allows room for expansion. And so those were the two primary reasons. And so even from the very beginning of the talks about merger, it was planned to get to one campus. So when we merged, we did begin to consolidate services that still were provided at Muskegon General Hospital to the Hackley campus. So about 2 years after the merger, we moved OB services and all of surgery from Muskegon General to Hackley. So that was kind of it was a sort of a 3-2-1 strategy. Now we've done the planning for the one campus model. Again, it's expensive. Our original plan would have cost somewhere in the range of $400 to $500 million to replicate all of our licensed beds in one place with basically a new construction. Now we're looking at a two-stage project, or wave one, wave two project, for substantially less money. And the main reason is we're not going to replicate all of our licensed beds any longer. With the advent of health reform, with all the pressure to reduce healthcare costs, to reduce hospital admissions, to reduce readmissions, we're finding that our inpatient census has been declining steadily for the past few years. So we don't think there's a need to have 420 beds any longer in the community. We think 250 beds will be sufficient.
So people are having more outpatient services and fewer
A lot of surgeries have
stays.
migrated to the outpatient arena. Good example is hysterectomy, where the woman's uterus is removed surgically. That used to be a 5 or 6 day length of stay in the hospital. It was an open abdominal procedure. Now it's being done with a laparoscopic approach, some with Da Vinci robotic with very small incisions, and some women are going home the same day. So, you know, that 6 day length of stay has now turned into an outpatient procedure. And that's true in orthopedics, general surgery, and other areas as well.
So you said the costs are significantly less. I remember in the newspaper it said $97 million. Is that proper
For
amount?
wave one, $97 million. We haven't priced wave two, but it'll probably be a similar dollar amount.
Okay.
So if we're in the range of $200 million versus our original plan of $450 to $500 million, it's substantially less.
Okay.
Now we're going to be utilizing the Mercy campus, the Mercy Hospital extensively, but we will be adding on with this project.
How about the Hackley campus? What will be left there?
That's still planning phase. Now wave one, we will move all inpatient services to Mercy and all surgical services. At Hackley still will be obstetrics, inpatient rehab, the long-term acute care hospital, Great Lakes Specialty Hospital. That's actually a separate licensed hospital that's in our system. And the behavioral health unit. So those services will remain with wave one. But with wave two, all those services are planned to move. Now with wave one, the emergency room at Hackley probably will be decommissioned as an emergency room, but will serve as an urgent care center. And just as when Mercy and Muskegon General merged, we closed the emergency room at Muskegon General, but we had in place an urgent care center with extended hours. We did quite a bit of imaging and labs on site at first, but as people got used to the idea that it was no longer a true emergency room, sicker patients migrated to the Mercy campus. Well, We'll do the same with Hackley, so that the ER will remain potentially even a 24-hour service at first, with pretty extensive services available, but continually educate the public to say the true emergency room is the one at the Mercy campus.
You mentioned a lot of this is driven by changes that's happening in healthcare.
Right.
Probably the biggest one is the Affordable Care Act, also
Right.
known as Obamacare, I guess.
Sure.
Part of that is in 2014 to start insuring a lot more people that are currently insured.
Yes.
Expanding Medicaid, but also insuring about 30 million people, I think, through health insurance outside of Medicare and Medicaid that currently don't have it. A lot of those people currently go to the ER.
Yes.
And, so do we have enough general practitioners in Muskegon to handle this? And is this part of what you're building towards?
Well, I think we are building toward that, and I don't think we have enough primary care providers right now. So we're looking at ways to make our recruitment package more competitive with other locations across the country. You know, this country is not really producing enough primary care physicians. And by that I mean general internal medicine, family practice, pediatrics. Some would include OBGYNs in the category of primary care. We're simply not producing enough primary care doctors to meet the needs of the country going forward. So we have to look at different models of delivering care. I think we will use nurse practitioners and physician assistants in our practices, working side by side with physicians to provide care to more people. So that, and also that's the other reason to have a strong primary care presence in the Hackley location.
Right.
You know, our utilization of the emergency services in the community is far greater than one would expect for a community our size. Even given the socioeconomic situation that we have, the illness burden that we carry. We're one of the sickest counties in Michigan, for example. That's part of the 1 in 21 project, is to try to improve our overall community health. But even given those factors, our ER utilization far exceeds what one would expect for a community our size. We're doing about 100,000 ER visits. Most communities our size would do 50 to 60,000. So we have to unburden the emergency room by offering alternatives in a primary care setting.
Right.
And that's critical.
And I mean, are you? Some might think, well, are you moving the ER to get away from people using it?
No, actually, the consolidation really is driven by the financial pressures that we're under. You know, you mentioned the Affordable Care Act. Part of the affordability of that act is cutting $700 billion out of hospital payments over the next 10 years. In addition to that, now we've seen the Republican budget, Paul Ryan's budget, which further reduces Medicare payments to both hospitals and physicians. In addition to the hospital reductions in the Affordable Care Act, there's billions of dollars in reduced payments to physicians. So the way they're structuring it is you pay less for each unit of service. Well, what it costs to produce a unit of service isn't changing. In fact, it's going up. So that's really not a smart way to do it. What they need to do is look at what's the total cost of care, pay a provider community to manage a population within lower costs. And that allows us to invest in other services. We have an example in our own primary care network. We're part of a program statewide called the Michigan Primary Care Transformation Project. We're hiring care managers in our practices to connect with our patients with chronic illness, to connect with our patients when they're discharged from the hospital, to get them into the practice, to address any barriers to taking their medications or following the right diet, to try to reduce their need for hospital care as a way of reducing costs. Now that's a logical way to reduce costs.
Yeah, and is that often called My Medical Home? Is that?
That's part of it. It's an extension of the patient-centered medical home, which Blue Cross has really subsidized over the past 6 or 8 years. And now this is an add-on to those patient-centered medical homes, additional services to help patients stay healthy.
Right. One example that I heard was when a patient leaves the hospital, they're often given a bunch of medications to take.
Yes.
And they often don't take them very well.
Right.
Like, I don't know, they told me to take all this stuff.
Exactly. Right.
To hire a pharmacist to follow up with all of the patients that have been discharged to make sure that they're taking them properly, answer their questions. And you have to hire a new person, but you actually, in the long run, save money. You might pay that person $100,000, but you save $500,000 because they actually take their medicines properly and are not readmitted.
Yeah, and that's a great model, but the only problem with it is it tends to be focused strictly on the pharmaceuticals. So our care managers that we've hired now in the network address the pharmaceutical issues, and maybe they connect the patient with our pharmaceutical assistance program for affordability, but then they also address transportation issues, diet issues. Do they have access to appropriate meals? What's their domicile like? Is it a safe environment, or is it at risk for falls? So we try to take a much broader look at it, but pharmacy is a big part of it too.
Okay. Speaking of transportation, with the move to a single campus, one worry might be, boy, now I have to travel farther to get care. Is there consideration for increased transportation availability?
Right. Well, that should be part of our planning for Wave 1. Even parking is an issue, on that campus. So if we get approval, and we're still pending approval from the Trinity Home Office, then all of the detailed planning begins, including enhancing, public transportation. Currently, we're on the bus lines at Mercy, just as Hackley is. But are there enough transportations getting out there? And I was pleased to see senior transport was reestablished recently. It was in the paper a couple of days ago, so that was good to see that. But yeah, it is going to be an issue. The other thing is, can we reduce people's needs to go to the Mercy campus, particularly the ER, by providing better primary care closer to home?
Right. Good. You mentioned the hospitals merged because they were both struggling financially. Is Mercy Health Partners in a better financial position now than they were when the merger took place?
Yes. Yeah, the merger saved, just in administrative overhead and some facility costs reduced at Muskegon General, in the range of about $12 million a year. So that's gone to our bottom line, not all of it, because we've had inflation and whatnot. But yeah, we're financially viable. That's why Trinity appears to be willing to support this kind of investment. But this investment is actually our money. We are going to have to fund this over time, but it's a sort of a complex financial relationship with the Home Office. We need their approval to spend it, but we have to show them a strong business case to support it, and that's what we're in the middle of doing now.
I see. One thing that's happened, we've got a Catholic hospital at the center. We've got a new pope.
Right.
It's been in the news maybe a little too much, but we've seen a new pope. Does that affect care at all in terms of how Mercy practices, what a pope might be in office, or initiatives and so forth?
Pretty far away from us, not only geographically but politically as well. Most of Catholic healthcare in the United States is directed by the Ethical or Religious Directives for Catholic Healthcare, which is developed and reviewed periodically by the American Association of Bishops. And then our own bishop, currently Bishop Hurley, has a great influence in the scope of services and in the way we provide care. So under the Ethical Religious Directives, we have a strong commitment to serving the poor, to having access for everyone, for end-of-life self-determination, for respectful and compassionate care at all stages of life. So that's mostly what guides us. Issues around reproductive health and sterilization are issues that are somewhat sensitive as the sole provider, and we work closely with the bishop's office and the diocese on those issues.
When you say you work closely, you follow what they tell you, or
we
let them know what
we are a
problems
Catholic
you're
mission.
seeing?
We're a mission of the Catholic Church, so we need to balance the need for this community to have access to a full range of services with the fact that we also are an outreach of the Catholic Church. So we walk a fine line, and I think we've shown ourselves to be good stewards as well as good providers of care in the community.
I mean, would you ever push them for change? I mean, just an example, contraception is an issue. I think I saw that 70-some% of Catholics themselves say they don't agree with that position of not having contraception available for people. And I think the new pope has said, well, if it's necessary to prevent disease, he might approve of it. Is that something you'd say, hey, can we re-examine this, or is that one?
What I would do privately is probably not a topic for this show. We, as a Catholic health ministry, conform to the Ethical Religious Directives, and we're not in a position to advocate or to lobby for changes in the Ethical Religious Directives.
I see.
Yeah. But we ensure that they fit within the needs of this community as well.
Okay. Yeah. And would those directives affect what a physician does in meeting with a patient within his office?
Well, yeah, there's an issue of degree here. Part of the ethical religious directives holds in high respect the physician-patient relationship and the privacy of that relationship. So while there may be some issues in the ERD that limit services, at the same time they promote the privacy and sacred nature of that physician-patient relationship. So that's where it's really hard to come right out and say this or that about it, because it really is something that has to be navigated.
I see. By the individual physician or by
Right.
administrators or both? Or?
Right. I mean, I suppose if a physician who worked for us were to open that clinic on Apple Avenue again that was recently closed,
Yeah.
we'd have some issues around that, you know.
Well, there's some issues, I think, on the way it was being run, but
Sure.
I guess you're speaking specifically to the services they were providing.
Yes, right.
Yeah, right.
Right. And that's what I mean by degree. So.
And so one of the things I think is admirable, maybe perhaps about the new Pope and about the Catholic directive is the emphasis on the poor and helping the poor. You mentioned some of the things that you're doing to ensure people get services, but what does Mercy Health Partners do in ensuring care for the poor of Muskegon?
Sure. Well, first we have a strong primary care network that's geographically dispersed and is open to all payers. Our physicians are compensated based on the work they do, not on the cash they generate. So we try to ensure that they are not incentivized to turn patients away.
So they're on salary, would that be the right?
Well, not really salaried, but it's an incentive-based, productivity-based compensation that doesn't take into account the payer source. So they get paid as much for an uninsured patient as they do for a Medicare patient. So that's part of it. We work closely through the Muskegon Community Health Project to try to promote the health of our population, including all segments of our population. We have a financial assistance policy where we provide substantial discounts from our fee schedule, even 100% discount for people below a certain level of income. And we actually post that. We encourage people to apply for that. You know, they might go to their doctor and he might write off the visit, but it's better to have them apply for the financial assistance policy because then their labs are covered. Some of we have the pharmaceutical assistance program that gets free medications for people. So in many ways, just the range of services we offer, the financial assistance, the fact that we have tens of millions of dollars of charity care that we expend every year, I think all speak highly for our commitment to the poor.
Okay, very good. Stephen Brill, reporter, had a big Time magazine report on hospitals.
I saw the headlines, yeah.
Okay, it's 32 pages long, it's huge.
Yeah.
But one of the things that he brought out was that often the bills that people get, and I mean, he showed some real horror stories.
Yes.
Are, if you don't have health insurance, the bills are astronomical.
They're terrible, yeah.
Yeah.
It's a terrible system.
If someone within Mercy Health Partners gets a bill that they think is just, I had no clue it would be this expensive.
Right.
What
We
do you
get
suggest?
complaints like that from time to time.
What do you suggest they do?
Yeah, we connect them with our patient services representatives, and if they call anybody in the hospital and say, I'd like to file a complaint, they'll be connected with our service representative, Mary Carlson, and she'll get them in touch with the patient service rep in the finance department,
Okay.
who then can offer them the financial assistance application. And depending on now, if their income doesn't meet the criteria for a discount,
Right.
then we're a little bit stuck. And frankly, it's not, I didn't read the article, but my wife did, but I believe it painted hospitals in a pretty bad light.
Sure.
But you have to look at the whole payment mechanism and how it's structured. So insurance companies in the past paid hospitals a percentage of their charges. So it was to the hospital's advantage to raise their charges because they got a percent of those charges. Then insurance companies said, well, there's this, our fee screen will pay this much for a service. Well, naturally, the hospital wanted to make sure it charged at least that much. Because if it charged less than that, it would get paid less instead of what the insurance company agreed to.
Right.
And then the lack of first dollar, of the lack of financial responsibility for many patients led them to be kind of ignorant about what things cost and what the charges were. So there was no sort of commercial or market-based limitation on the fee schedule.
Right.
So the hospital has to not only collect from insurance, but they have to provide service to uninsured patients as well, who pay nothing. I mean,
Sure.
in spite of the high charges.
Do you know what percentage of your...
From the uninsured, we collect about 6% of our charges. So,
I see.
we're not collecting 80% or 60%. We collect about 6% of what we charge people without insurance. And that's the piece that never makes it to the press. They look at the invoice, at the huge bill, but they don't look at what we actually receive for those. But we're not allowed to have a separate fee schedule based on people's insured status. We have to have a single charge master that applies to everyone. That's why we have the financial assistance policy, so we can discount how much people pay us, but the charge still has to be the same charge. And we charge insurance companies the same, except they agree to pay us less, and we've signed a contract that allows them to do so.
Right, right. Now, it seems like it's kind of like that. If you go to look at a couch for sale, for example, they'll say, here's the retail price.
Yeah, and here's our discount.
Here's our discounted price. But that retail price is ridiculous. Nobody pays that, you know?
Right, pretty much nobody pays the retail price.
Should I think that if I'm an uninsured person and get a bill from the hospital, I'm getting the price that nobody pays? I mean,
right.
And should I call and say, hey, can I get,
well, first thing you should do if you
pay
can
what
afford
Medicare pays?
If you can afford it, the first thing you should do is buy insurance, so you take advantage of that insurance discount.
Yeah.
If you can't afford insurance, chances are you're eligible for our financial assistance program, in which case you'll see a much lower personal obligation for those services.
Okay, okay, good, good. This leads to a question. Why is it that healthcare is so expensive in the United States compared to other countries?
Yeah.
I know I saw that an appendectomy in the U.S. costs about $13,000. And in Canada, it's about $5,600. In Germany, these are wealthy countries too.
Sure.
In Germany, it's about $3,000. Why the cost difference?
Yeah, well, I think you look at a number of things. Pharmaceuticals, for example, are much more expensive in this country than they are anywhere else in the world. And part of it is, even though we have a government program, Medicare Part D, that purchases pharmaceuticals, they don't really negotiate a price.
Right.
They don't act like a pharmacy benefit manager, they simply pay. So those companies that manufacture those charge a lot here to make up for the fact that they can only charge a discounted price elsewhere. Our physicians are paid more than in other countries, but they also come out of medical school with $200,000 debt on average, whereas in other countries their whole medical school is paid for.
Right.
In Canada, everyone has insurance. So the hospitals don't have to charge more to insured in order to make up for the non-paid patient who has no insurance. We don't have that arrangement in this country. So I think there's lots of reasons that go into it. When people look at the global cost of care in the US compared to other countries, we have a very heterogeneous population. We have large segments of people living in poverty, with chronic disease. And if you look at our health status indicators, they're poor compared to most other industrialized countries.
Our wealth, yeah.
But that's a driver of healthcare cost. People think, well, if you spend the money on medical care, your health status will improve. Well, medical care doesn't drive improved health status.
Right.
It's a result of it.
And I think you're right. Overall, that's a real concern, and hopefully we'll get better on that. But I guess it wouldn't speak to the appendectomy itself, that particular.
Well, except they have to charge that to this patient with insurance so they can do the appendectomy for the patient with no insurance.
I guess.
I mean, that's a substantial
I'm not
part
sure,
of our population, right?
Yeah, I'm not sure that's what's driving most of the cost of that appendectomy. I could be wrong on that. One thing I know the Catholic health system, or maybe Trinity, has advocated is a single payer plan. You mentioned Canada has something like that. Is that still the case, that the system would like to see a single payer plan?
Well, to my knowledge, Trinity Health, my sponsor organization, supports coverage for all. I don't believe they've put a foot in the ground saying we want single payer. So I don't know what the American Council of Bishops has said either. And then there's the nuns have their own organization, and the Catholic Health Association is largely managed by sisters, and I believe they are supportive of a single payer model. They certainly were supportive of the Affordable Care Act. Personally, I think in this country, where capitalism is king and competition and the market have shown, in my opinion, the best success at enhancing quality and lowering cost, maybe with the exception of healthcare. I think more market influence in healthcare pricing would be beneficial. And based on my own experience with Medicare and Medicaid, a single payer government run health system will not be successful in this country.
What makes us different? I mean, it seems like if these other countries are providing, as you mentioned, better healthcare
Right.
outcomes at a lower cost, by doing it in these ways, by having a single payer system, there might be some market incentives. I mean, Canada has for-profit and nonprofit hospitals and providers. I mean, can't we learn from them and try
We
to?
haven't. I mean, if
Yeah.
you look at the Medicare system, pricing is based on politics. It's not based on any kind of rational, economic-driven model. It's based on politics. So the physicians were supposed to have their pay cut by Medicare by 31%, but Congress delayed it and delayed it and delayed it, and may actually eliminate that formula. Hospital payments have been going up 3 to 5% every year, while physician payments have been flat. It's because hospitals have stronger advocates in Washington than physicians do. You know, running healthcare through a political system makes no sense to me.
Right.
Just at a principle level.
Some I've heard have advocated it, maybe if you have a single payer, have the head of it be, or those, maybe it's a group in charge, be more like the Federal Reserve, who kind of connected,
Yes.
but separate nonetheless.
Yeah, I haven't seen that model proposed. People talk about Medicare and Medicaid for all, and those models are heavily politically driven and not rational.
I see.
That's what worries me, I think.
One last thing is, we've talked about, you've mentioned the 1 in 21 program, and to increase, I mean, we do have an obesity problem, and winter has been pretty strong this spring. And so I'm sure people haven't been getting out as much as they should.
Yeah.
I know I haven't. What is the hospital doing and the system to encourage people to lose weight, live a healthier lifestyle, be more active?
Well, we are trying to get behind 1 in 21. We're on committees. We support the activities. We just had the RIDE event last weekend at the mall. I don't know if you're able to get down there. I was working with one of the teams.
That's the spinning, the bicycling.
The stationary bike race. Yeah, it was a great event. A lot of people at all ages engaged in that really good physical activity. The Seaway Run, we participated in sponsoring that this year. For our own employees, we offer health insurance products that incentivize healthier behavior. So you do a health risk assessment. If you identify problems, you sit down with your physician and develop a plan. As long as you conform to the plan, you continue to get cheaper insurance with richer benefits. If you don't comply with that program, you end up paying more for your insurance and your benefits aren't as rich. We support Access Health in Muskegon that has a similar plan called the 3C program. So, engaging insured individuals in programs to promote wellness helps us as an employer lower our insurance costs, but also helps our employees be healthier. Right. So, this is something where we feel our role is to partner with other community agencies. We're basically in the sick care business. That's what we do really well. Right. Health is driven so much by environmental factors, dietary factors, that are pretty much outside of our primary sphere of influence, but we want to partner with community agencies on those issues and be a strong proponent for a healthy community.
Well, good, because I know, people might say, well, you profit from people being unhealthy.
Oh, sure, I know they say that.
But you do want a healthy society.
It is part of our mission statement to promote a healthier community.
Good. Well, Rem, thank you for being with us.
You bet, Andy, it was a pleasure.
Yeah, and good luck with the transformation.
Thanks, it's a lot of work ahead, but it's going to be the right thing for us.
I hope so.
Thank you.
Thank you for watching Timely Topics. We've been talking to Dr. Remington Sprague, the Vice President and Chief Medical Officer at Mercy Health Partners. Until next time, I hope you have a great day.